Let's get going. Thank you everyone for taking some time to join today. We had over 100 registrations for this webinar, which for us is pretty exciting, and I think it reflects the importance of this issue right now. We have, I'm having a little technical glitch. Just give me one moment and I'll continue. There, a little screen flickering issue, but I think it's resolved. All right. So I know this is a particularly challenging time for everyone with, excuse me here. I know this is a particularly challenging time and tumultuous time for everyone. And there's a lot of challenges with respect to helping students and other learners as best you can right now, and looking ahead towards the summer and even into the fall. So there's been a movement towards virtual patients and virtual simulations for some time. As we realize the limitations of the in-person simulations and the mannequin-based simulations, and also the challenges around logistics and scalability. But the COVID pandemic has certainly caused us to expedite implementation of virtual simulations and other technologies. So what I want to do today is provide a bit of an overview of the types of technologies and the types of structures of virtual patients or virtual simulations that exist. My name is Tim Willett. I'm the president and CEO of Simulation Canada. And way back in a previous life, when I was working for the University of Ottawa, and then for a group called CRI, Critical Care Education Network, and then for the Royal College of Physicians and Surgeons, I actually worked a lot more with virtual patients than I did with in-person simulations. I will disclose that I've been out of the front lines of building virtual patients for a few years, but I'm happy to share the experiences I've had and the knowledge I've had, and the a review of some of the evidence that I've completed recently. Just for the sake of managing the webinar, everybody is kept on mute. Please feel free to enter any questions in the question area. Nicole is online with me, and she's going to help keep an eye on any questions and answer them right away if she can. And if it's any questions about the content itself or certain platforms, we'll hold those until the end. So let's jump in. Right, so what am I talking about with respect to a virtual patient? Here's a definition that comes from David Cook and Mark Triola in a review they did in 2009. And this definition is still used in the Simulation Dictionary, 2nd edition. But it's deliberately quite a broad definition because of the variability in structure and technology that exists within this world of what's considered to be a virtual patient. So based on this definition, there are really 3 key aspects. Virtual patients are computer programs. They're differentiated from virtual reality in that you don't need a specialized headset to be immersed in it, right? So sometimes we see them called screen-based simulators because of that. They may well be a three-dimensional environment, but you're interacting with it through a screen, through a 2-dimensional screen. Like all simulations, it replicates some aspect of a clinical encounter. And users are actively engaged. So users have to interact, they have to make decisions, and they'll get feedback on their decisions so that they can learn. So there's been a couple papers published that work on trying to classify these various types of virtual patients. The second paper mentioned there from Kant tries to differentiate different terms used within the world of virtual simulation, including terms like virtual patient, e-simulations, screen-based simulators, and virtual reality. For the purpose of today, what we're really talking about is those virtual patients or screen-based simulators. Then if we go into the Kanonowicz paper, they do a deeper dive specifically into virtual patients. What they did is a literature review to look at information published about different types of virtual patients. And they put together this matrix where on one axis they looked at the technology that's supporting the platform. And on the other axis, they looked at the competency domain that it was meant to address and mapped out where these papers fell. And they found certain clusters emerged. So I'm going to be roughly using this framework to present the different types of virtual patients, but expanding especially on a couple of these to look deeper into the architecture, the pedagogical architecture within those types of platforms. So the first is what those authors called a case presentation. And this is essentially a linear virtual patient. The idea is the learner begins the case, there's a defined start point, a defined end point, and a number of steps in between, but there's only this single navigation path. So they move from one node to the next. Now, on each node, they may get new information. There might be a little quiz for self-assessment. There might be some media, like a video. There might be something interactive, like a virtual manipulative. They might need to commit to a certain diagnosis or certain management choice. But ultimately, the decisions they make aren't going to change the progress of the case. But nonetheless, they'll get they'll get feedback as they go on their decisions. Then there's a cluster of virtual patient types that Kanonowicz and his colleagues called interactive patient scenarios. And these can actually manifest in several different ways. So you'll see a few different types presented. The first is exploratory type. So in exploratory virtual patients, the learner begins at a set point, typically being introduced to a patient or client, and the context of their challenge and their situation. But from there, there's many different options the learner can take. Typically, what these cases try to do is reflect reality in that when you meet with a patient, in whichever setting, there's almost unlimited things you could choose to ask, examinations you could choose to perform, ultimately tests you could choose to order. And that variety is tried to capture in exploratory cases. So after meeting the patient, it's up to the learner what they want to do. What questions do they want to ask? Do they want to delve into a history of presenting illness first? Do they want to talk with a family member perhaps? Are they concerned about the way the patient appears and want to jump quickly to a physical examination or assessment and get some vital signs? one of the challenges of this type of case is presenting all these different options. So often there's extensive menus and submenus to make these choices. Some virtual patient platforms have started to include search boxes so that you can search for a specific question that you want to ask. Then at some point, after all this information gathering, so after you've collected all the history that you want, reviewed relevant materials, looked into their chart potentially, performed some physical examinations and got the data back from those, potentially sent somebody for certain testing or diagnostic imaging or a consultation. At some point, these exploratory cases will ask the learner to commit to a decision of some sort. It might be a decision about diagnosis or nursing diagnosis. It might be a commitment to a certain treatment plan. Then the learner gets feedback, and the feedback could be based on the appropriateness and the efficiency of the information they gather. So did they ask the right questions and do the right exams and order the right tests that they should have? Or did they do extra investigations that really weren't appropriate or indicated? And also efficiency. In a case like this, you could theoretically just ask every question that the system will let you ask and do every exam that it'll let you do and order every test. But that's hugely inefficient and not at all reflective of what we would do in real life. So often the feedback includes some kind of scoring around the efficiency of that information gathering. And then when the learner does have to commit to a decision, feedback on their decision and the rationale for it. And what several of these systems have started to do is include trackers in the background where either the time it would take or the cost of any option that they choose to pursue. So if you choose to do an MRI, it's going to be an expensive investigation compared to if at this point you limit it to a history and physical. And at the end, the learner can actually get scored on an approximate cost of their information gathering, and also feedback as to whether that's appropriate. Certainly if an MRI is indicated, then it's appropriate to order an MRI. But if there's cheaper ways of doing it, if an X-ray or CT would have sufficed, or an ultrasound, then they'll get that feedback and see the difference it can make to healthcare costs. So this can really help not only with learning the right thing to do, but also with approaches around choosing wisely and choosing cost-effective but still appropriate choices. Another type of interactive patient scenario is a branching scenario. So the one thing about the exploratory scenarios is that the patient's situation generally doesn't change. The learner's gathering information about the patient as they are, but the patient's status or their situation itself doesn't change. So that's great for assessing someone's ability to collect data and reason through it and come to a decision and propose a treatment plan. But it doesn't necessarily let you see the impact of decisions. So if your focus is more on wanting your learner to make decisions and see the consequences of those decisions and react accordingly, then branching virtual patients are a better choice. Again, there's a series of nodes, and these can all be connected in whichever way you want. And the case unfolds as the learner goes from node to node. But the choices that the learner makes at any given point affects how the case evolves. And it may affect the evolution of the case in the sense that their patient might get better or worse, or perhaps their feelings and their affect will change, or perhaps the patient's situation, including their social situation, might might change depending on the actions taken. So this allows learners to see the impacts of their choices in real time and react accordingly. These cases can be designed so that learners, once they make a decision, are stuck down a certain path. And in some cases, and again, it depends what your learning objectives are and what would be possible in reality, perhaps future decisions could allow the learner to recover and get back on the right track. At the end of the case, sometimes from node to node, and in some cases at the end of the whole case, the learner gets feedback on their decisions and why they were right or not the right decision, and what the right decision is and why, importantly, why it's right. In both these cases, typically learners are given the opportunity to repeat the case and try to be more efficient and more accurate the next time through. Another type of interactive patient scenario, and 10 years ago when I was working with virtual patients, there were very few options for what I'm calling responsive virtual patients. There were maybe one or two platforms that existed. And now we've seen an explosion. There's 5 or 6 commercially available platforms and a couple of academic creations as well. And what these virtual patients allow you to do is kind of like the branching one. They allow learners to make decisions, and the decisions immediately impact the state of the patient. But the decisions and options, rather than being a finite list of 2, 3, 4, 5 options, they take a more open-ended approach, kind of like the exploratory scenarios. And these are used commonly for acute care or critical care, where you won't necessarily proceed through a case in the typical order of a history and then an examination or assessment, and then any tests or examinations you want to do, and then coming to an early diagnosis, etc. But rather in a critical situation where you have to switch between ABCs and information gathering back and forth dynamically. And you want to be able to see how your interventions affect the patient in real time. So if there's a breathing issue and you apply oxygen, you want to see what it's going to do to the O2 sats. And if they don't get better, you want to react to that and escalate your breathing interventions immediately. If there's signs of hypotension, you need to address those right away, or changes in consciousness. So these cases are much more complicated because in the background, there has to be some kind of physiologic, I'll say a physiologic engine. It doesn't have to be a full physiologic model of a patient, but there has to be some kind of algorithms that track what the patient's state is, how that state is going to change based on the interventions that someone does, and how future questions or future investigations the results will change based on the interventions done so far. So the example I give here is if you have somebody come in and they're anemic, and then part of your management is to give a transfusion, you would expect, and then you do another CBC, your results going to change based on your intervention. So some of these cases have a predefined endpoint where you need to resuscitate someone to a certain point of stability, and then the case will draw to a close. And sometimes they're more open-ended, and they're meant to be done with a facilitator, and that expert facilitator will work with an individual or group of students to work their way through a case, and the facilitator will decide when to draw it to a close. The feedback in this case isn't just on the choices they've made in terms of information to gather and interventions to do, but also on their prioritization. And did they recognize critical issues and respond to them appropriately as a priority over other actions? In many cases, these virtual patients now use an avatar, either two-dimensional or three-dimensional, so you can see visually what the patient looks like and any equipment that they might have on. There's often a virtual monitor, so you can see their vitals in real time. Some platforms use more of a flat picture of either a real person that changes over time, or an animate, like a drawing that changes over time, and some of them use a three-dimensional avatar. The next type of virtual patient is what Kanonowicz and his colleagues call either a human standardized patient. In the case of a virtual patient, it's a videotaped human standardized patient, or a virtual standardized patient. And either way, the pedagogical goal of these scenarios is communication, where the goal is to recreate what would be a natural conversation between the learner and the actors in the simulation, whether that's a patient or their family or colleagues. There's a couple different approaches that these could take in order to facilitate that. One is to provide a list of options, kind of like a branching case or an exploratory case, where learners choose from lists what they want to say and when. And what they choose to say will impact what the virtual patient responds to them. It could affect how they, not only what they say, but their affect. But more and more we see these patients using natural language processing, and in some cases some artificial intelligence or deep learning, in order to provide a smoother, quicker, and a more open-ended interactive experience. So learners can either type in questions, and the computer will interpret that and match it to a response from the patient, or learners can verbally speak to the patient, and they'll respond. Some of the early studies into this type of virtual patient indicated that certainly the technical aspects of communication, so the questions you want to ask, the way to respond, certain words to use or not use, can be improved over time. But the true interpersonal, the emotive aspects of communication, demonstrations of empathy and active listening and compassion, are certainly more challenging. At least from the evidence I've seen, it's not clear whether this type of virtual patient can really impact that learner's emotive quality of their communication. Some of the newer types of virtual patients, not only will the words that the virtual patient responds with change depending on what the person asks, but their affect and their will as well, and they'll have more, both visually and in what they say and how they say it, express more emotion in their response. And it'll be interesting to see if that can better tap into the emotional and nonverbal aspects of communication. I just see a question from Veronique. You asked, what is AI? That's artificial intelligence. Sorry. There's a classification of virtual patient software that Kanonowicz and his colleagues called high fidelity software simulation, which I have to admit, I don't really like that term because it's so vague. But digging into what they mean by this, they're talking about procedural simulations. So virtual simulations that are meant to emulate a procedure as accurately as possible. That is, as accurately as possible without having the manual hands-on component, right? So without having actual equipment in front of you, or an actual simulated or real body part in front of you, trying to mimic the procedure. some of these platforms are actually getting quite sophisticated and quite good. That what they can teach can range from things that are pure manual procedures, such as surgery, to things that involve a little more decision making and monitoring of the patient as you go through, like conscious sedation. The strength of procedural simulations like this is that they provide the background knowledge that people need to know to effectively and safely perform a procedure, and the steps of the procedure, and some of the decision making along the way, like when there might be a sign or an issue that would cause you to change course in how you do the procedure. The limitation, of course, is that the psychomotor aspect of doing the procedure can't be replicated. But that seems to be okay. Our brains learn, this is some more recent research, our brains seem to learn the procedural knowledge and the decision-making parts of a procedure differently than the psychomotor aspects. So it seems to be okay pedagogically to break these up, and actually having learners go through procedural simulations before coming into a sim lab to do the psychomotor, the hands-on component, can expedite the learning when they do get to that psychomotor component. So they need less time in the simulation lab to achieve a same level of performance. So that can actually reduce the workload and the burden on the physical and in-person simulations when you get to that point. The next type identified by Kononowicz and colleagues, they call a virtual patient game. Again, kind of a generic, not very accurate term. But when you map that to the pedagogy that it's meant to address, these are really meant to be collaborative experiences with a goal to enable team-based learning or interprofessional learning. So in these virtual patients, you need a platform by which multiple people can connect, either synchronously in real time or asynchronously, maybe not all at the same time, but they all need to be able to connect to the same virtual patient and interact with it. Often the facilitator is brought in real time as well. So one way of doing this is through virtual worlds. A virtual world such as Second Life. So a virtual world is a three-dimensional environment where the learner is portrayed as an avatar, as a character, and you can move around in this virtual world, interact with other characters and other people, and interact with objects. And in doing so, you can bring multiple people together in the same virtual space. They can communicate with each other, and they can each be doing things, in some cases doing different things, in order to assess the patient and the situation and make decisions and intervene. This could also be done asynchronously. So a project that I worked on some time ago at the University of Ottawa was around palliative care and interprofessional approaches to palliative care. The approach we took at that time was, rather than a virtual world, we had a patient represented by short video and audio clips, where we worked with a standardized patient to act out these different clips, and developed a map of a conversation with the patient. And when you met the patient, there would be a dialogue, and then depending on what after hearing what the patient says, you could choose how to respond or what question you wanted to ask next. And much like kind of like a branched virtual patient, it would take the conversation in different directions. And our hypothesis was that learners from different professions would take the conversation in different directions and therefore learn different information. And only by coming together after meeting the patient and sharing what they've learned could they come together and actually formulate a true interprofessional treatment plan. So that was a lower tech approach, but also quite effective in achieving its goals. An obvious advantage to this is that it overcomes some of the logistical challenges in that participants can be geographically separated. And if you take an asynchronous approach, participants don't necessarily need to connect even at the same time. Actually, I'm going to jump back. I think it's worth noting that there, and I apologize for not writing this down, but there are other types of virtual patient games or immersive 3D environments that aren't necessarily meant to be um, um, focused on teamwork or interprofessional learning. In some cases, these virtual environments are used almost like a branching case or a responsive virtual patient, except instead of being done in 2 dimensions, it's done in a virtual world. And in some cases, they're meant to expose learners to a certain environment and allow learners to explore a certain environment and the activities that go on. A good example of this is disaster response. And I've seen homelessness simulations like this. I believe Médecins Sans Frontières uses this kind of simulation to expose people virtually to being in a refugee camp, where learners can explore the area and develop an appreciation for the environment this way. So jumping from those different models and structures of virtual patient, and I'll come back in a little while to look at some examples. But as people were registering for this webinar, some questions came in around research and evidence. So I wanted to touch on this briefly. A couple of review papers have come out recently that do a decent job of synthesizing the current state of the evidence. One is by Kononowicz and his colleagues, so the same author as the classification paper I mentioned earlier, and a few key findings that they came across. In all the studies they looked at, virtual patients perform more effectively than traditional learning approaches when it comes to improving skills, and particularly cognitive and decision-making skills, but also, as you saw, the technical aspects of communication and the knowledge and procedural parts of psychomotor skills, at least as effectively, and in many cases more effectively than traditional educational techniques. And when it comes to knowledge outcomes, so lower level on Kirkpatrick knowledge outcomes, they're at least as effective as traditional education. Authors noted, however, that in many cases, the quality of and the rigor of the research behind that is of low to modest quality. Nonetheless, this is looking at dozens of studies, so these trends are seen across multiple studies. The impact of a virtual patient approach compared to a traditional approach is greater when it's applied, when the knowledge, and when it's not just rote knowledge, but it's applied knowledge and skills related to problem solving. When it comes to choosing an active learning method, so if you want to move from something more didactic to something more engaging and active, the authors conclude that because there seems to be equivocal effectiveness, potentially slightly better effectiveness of virtual patients in certain situations, it's reasonable not just to consider the learning objective, but other factors such as the cost of use, scalability, time flexibility, personnel shortages and human resource needs, and the availability to access learning remotely and from different settings when choosing which method you want to use. A caveat that was interesting they picked out is that they say presenting realistic patient scenarios with a great degree of freedom. So thinking about these open-ended type of cases and exploratory cases where learners can essentially do anything they want, can actually be somewhat detrimental if your learning objectives aren't well matched to that kind of experience. This ties in nicely to the research that's been done around self-directed learning and regulated and directed self-regulated learning, where learners left it completely open in an unguided space to explore and try to learn and try to determine what they need to learn, often struggle. And some degree of guidance is necessary in order to allow learners to self-regulate and know what's expected of them and have a direction or a goal to work towards. So exercise some caution in some of these open-ended virtual patients, in that they're not too unstructured, and at least even if the learner goes in and has a huge array of choices to make or information to choose to pursue, they go in knowing what their goal and their purpose is, and they can get feedback on that. These authors also identify some areas for future research. They note that a lot of the previous research is media comparative, meaning we're going to compare learning videos to learning with still photos, or we're going to compare a 3D avatar to a real patient video. And a lot of those studies aren't terribly informative, because when you change the media, you fundamentally change the way the learners also interact with it. And it's very difficult to say that you've controlled the experience of learners, because so much is different between the different platforms. Rather, changing a pedagogical approach and examining or comparing the different approaches from a pedagogical perspective rather than a media perspective would be more informative in the future development, or in guiding the future development and application of virtual patients. A lot of this research has been done in medicine, and they encourage research to be done in other professions as well to complement the and to round out the full body of research. And for some of these initiatives to go beyond examinations or beyond the evaluation at the level of learner satisfaction and knowledge gain, but also to look at translation into clinical practice, potentially as so far as patient outcomes, which is always a challenge in educational research, and also cost effectiveness, because we know the scalability of virtual patients. Once you invest the time to develop a case, the scalability and the number of learners you can reach in a shorter period of time is much greater than in-person high-fidelity simulations that take a lot more resources to work learners through. The other advantage with virtual patients is we know from the clinical reasoning literature and the expertise development literature that learners become more expert at solving problems by practicing solving lots of those problems. And virtual patients allow opportunities for students to go through many more cases in a shorter period of time than what you'd be able to do in a simulation lab. So again, there's opportunities for cost effectiveness comparisons there. Another paper by Peddle and colleagues looked specifically at non-technical skills in health professional education, slightly less focused on medicine and looking at other health professions, but still included medicine. And they found that interactions with virtual patients can indeed be used to develop, measurably develop communication skills, teamwork skills, and decision-making skills. And learners feel that these assist the translation of their knowledge to clinical practice, and can help prepare them for clinical placement. They also note an important finding that learners, especially learners who have not had much exposure to the clinical environment, it helps them understand their role, helps to socialize them into their healthcare role. Even if you're not doing an interprofessional simulation, you could build into these virtual patients activities that reflect the role of the healthcare provider, and even build in other healthcare providers and the information that they would bring to help students understand their role with respect to others. When they dug into some aspects of the educational design of the simulation experience, they found that it's important to consider not just the virtual patient, but how it's built into a bigger curriculum and the sequencing of other learning activities surrounding the virtual patient. So that could be making sure that there's some knowledge, relevant knowledge provision before encountering the patient, some understanding of, for students, of what they're supposed to do and how many times, or are they supposed to repeat it until they achieve a certain a score or performance level. And then what happens after? Is this meant to prepare students to then go into a high fidelity lab or some other experience to build on this? They also explored the theme of authenticity and found that authenticity has an impact on learner engagement. And they define authenticity in this paper as eliciting emotion and empathy, which is particularly important when there's a communication aspect. And portraying variability. Now, portraying variability relates back to the development of expertise, again, where we develop expertise at problem solving by solving lots of problems of a certain type, but it's important that there's variability in that problem. And only by working our way through several cases and several situations all around the same issue, the same problem, but where there's variability in the way it's presented, or the way that the data reveals itself, do we start to understand those subtle differences between presentations of the same problem, or the subtle differences that could indicate there's a different underlying problem to what superficially seems to be a similar presentation. So encapsulating that variability is important. Finally, there was a question that came in ahead of the webinar about using simulation, virtual simulation, to replace clinical education experience. And of course, that's a particularly important question right now. All I was able to find was one report. The report was published by Shadow Health, which is a company that produces a virtual patient simulation platform. So immediately there is a risk of bias in this report that I think we need to acknowledge. That said, the report does draw on credible peer-reviewed evidence in its summaries. It summarizes the literature that exists comparing simulation-based learning to clinical placement-based learning, and how simulation can replace some clinical placement time as part of a hybrid curriculum where your clinical learning is partly done in a sim lab and partly done in clinical placement. And I'm sure most people on this call are probably familiar with that literature. They summarize some of the comparisons of virtual simulations to mannequin-based simulations, and there are some comparisons showing not only in some situations that virtual simulations are equivalent, but in some they're superior to the mannequin-based simulations. And building on this provides theoretical justifications for how virtual simulations can be part of a hybrid curriculum and balance and complement clinical placement learning. However, there are so few studies that directly investigate using virtual simulations to balance clinical placement learning, that at least in this report, that link was theoretical and kind of builds on different pieces of evidence, as opposed to being able to summarize the literature directly showing the role of virtual simulation in creating a hybrid clinical curriculum. So unfortunately, at least from the literature I was able to find, we don't yet have that direct connection. The other bit of research I wanted to summarize was research around the design and feedback, design of virtual patients and some feedback. There's a really nice paper written by Nancy Posel, who's at McGill in Montreal, 12 tips to support the development of clinical reasoning skills. And they go through a number of different considerations that could help you choose not only what platform to use, but how to build the case, how to build in feedback, how to structure it as part of a bigger curriculum. And then I've listed some other papers here that that really do a nice job of rounding out this evidence as well. Margaret Virchow and her colleagues in Ontario have done some excellent work around virtual gaming and design features and how that affects the student experience and learning, and also different models of building debriefing and feedback into virtual patient use. Bateman and colleagues have done a grounded theory study into virtual patient design features. And Rachel Alloway and David Tops, who are in Calgary, have done some extensive research around virtual patient design and implementation. The paper I've highlighted here talks about how virtual patient activities, rather than looking at the design features intrinsic to the virtual patient, they did an exploration of how the virtual patient could be used as part of a broader learning package, and comparing, say, independent self-learning of a learner versus working through virtual patients as a group versus having a virtual patient as part of a scaffolding exercise that builds up to a high fidelity simulation, and some other ways of building a curriculum around a virtual patient. So on that note, I wanted to jump into examples. I'm aware that we're short on time, and I wanted to focus on those different models of virtual patients and their strengths and weaknesses. And you can see how, depending on your learning objective, that will influence what virtual patient model you want to use. If your objectives are more around teamwork, and interprofessional communication and collaboration, you might choose a different platform than if your interest is around building communication skills. And again, it'll be different if you want your learners to develop more fundamental knowledge around certain case presentation. Different again if you want learners to be able to test their ability to pursue information and gather data and compile it and analyze it to come to a treatment plan or a diagnosis. And different again if you want learners to be able to apply that clinical reasoning, make treatment decisions, and see how that impacts their patient in real time. Over the past couple weeks, we've been trying to compile virtual simulation platforms that we've come across. And so the link I show here takes us to the page where we've compiled that. I'm just going to switch over my screen sharing to my web browser here. There we go. So here's the page we've put together listing virtual simulations. I've tried to cluster the Canadian ones near the top. But you'll see this fairly extensive list right now. And what I've concluded on this list are actually just what I would consider virtual simulation platforms. So the software foundations you could use to create multiple virtual simulation cases. So these aren't just links to individual cases, but links to those platforms. And many of those platforms have several cases, and many of them allow the authors to, or the educators to build their own cases or adapt cases as well. There's many commercial options, but also some really good free and open source options as well that are worth looking into. Again, your decision needs to be guided based on what are your educational objectives that you want to achieve for your learners. What kind of resources do you have in terms of finances to potentially license an existing off-the-shelf package that would come with cases, versus how well do those cases line up with your teaching needs would it be better to take more of an open source platform or one that has an authoring interface, and that would allow you to build your own cases or work with faculty to build your own cases? And ultimately, it might be that no one platform will do everything you need it to do, because perhaps your learners have some needs both around the clinical decision-making and problem-solving aspects, but also communication or also interprofessional collaboration, or also learning some procedures. On that note, we have 5 minutes left, so I'd be happy to jump over to questions. I think I've covered some of the questions that came in ahead of time. So Kimberly Buttonen from Douglas College asked, what are the evidence-based best practices in assessing technical and non-technical competency development online? So some of the papers I pointed out, particularly the 12 tip papers and the ones by Margaret Verkyle and the systematic reviews would touch on those best practices. There's that one paper specifically on non-technical skills that's worth a look at. And if you look also into the literature on virtual OSCEs, there is some literature. It's not extensive, but there is some literature around psychometrics and doing more formal assessments in the virtual space. Second question, what methods are there used to produce an effective simulation that's applicable to critical care scenarios for resuscitation? What you want to look into in this case is those responsive virtual patients. Some of the ones that pop off this list to me, Body Interact is a responsive one. Open Labyrinth could be used to build a somewhat responsive, not completely open-ended, but at least a somewhat responsive virtual patient. Where's the other one I'm looking for that I know comes on? Full Code is a responsive virtual patient. I have a feeling at least one other is here too. You'll have to forgive me, I'm not sure offhand which one it is. Question around the use of simulation to replace clinical education experience. We touched on that. And evaluation or just student completion, which comes from Nicole Moen at Douglas College. It's an important question. That most of these platforms do go beyond simply student completion as a metric, both for formative and summative purposes. Many of them will provide data back to the student and will provide data to a faculty supervisor, not just about their completion, but about their scores. Some of them will allow you to see the pathway that certain students take. So if you notice a student really is struggling with a certain case, you could jump in and see their information gathering or their decision-making choices and processes, and be able to tailor some more directed feedback to them. And in some cases, the scoring is quite sophisticated, like the exploratory ones that might be able to track how much time in real life it might take to investigate a patient the way the person has chosen, and the cost associated can provide some much more sophisticated metrics. I'm looking at some of the questions that came in too. Lynn asks, Lynn Nask asks, good afternoon. At the end, could you provide us with the PowerPoint and some free resources you talked about, like these? Absolutely. I will post this recording and the PowerPoint on our website. Barbara Wilson-Keats asks the same thing. Yep. She asks about, is Shadow Health part of your virtual simulation platforms? Yes, it is. The name of their platform is Digital Clinical Experiences. So it's listed under D. Oh, and she found it as I was saying that. We've got a couple minutes left. If anyone else has any other questions, or if there's a specific platform that you're curious about, please feel free to enter it into the question area. And I'm happy to take a moment to answer. Otherwise, if anyone wants to contact me after this, please feel free to, and be happy to answer any questions. Barbara asks, is anyone out there using vSim to replace final nursing practicums? So I throw this back out to everyone on the webinar. If you are using some virtual simulations to make up for final nursing practicums that should be happening right now, please just post a quick note in the question and answer box, and I can share with everyone that you're working on it. Cynthia from McEwen says they are. Shadow Health is offering a discount right now, I think 50%. That could be, Lynn. On this webpage that we built, if you scroll down a bit, I've been trying also to collect information on the different platforms that are offering discounts because of needs from COVID. I see that I don't see Shadow Health there, so let me look into that. And if so, I will add that to the list. Thanks for drawing my attention to that. Sharon, you asked about Simtix. Simtix is a pretty strong procedure simulator. So if you need your learners to learn about different medical or nursing or other allied health procedures, Simtix is strong on that. It's a commercial solution. I know they have a lot on ultrasound in particular, but not just ultrasound, a whole variety of clinical procedures. I don't personally have a lot of any experience using that platform, but I know it's well established. Have I had any experience working with accrediting bodies to allow simulation as part of training hours? This is certainly a challenge in some provinces and with some professions more than others. In Alberta, the nursing college, and anyone online from Alberta can correct me if I'm wrong, has actually issued a guidance where they will recognize the use of simulation as part of clinical placement time. I think the Canadian Paramedic Association has issued some guidance around that, but ultimately they don't do the accreditation, is my understanding. So that it's more of a guidance than an official accreditation body recognition. Coincidentally, I've been meeting over the past few months with Accreditation Canada, who, as many of you know, have taken over the accreditation from the Canadian Medical Association for many allied health professions programs. And they are keenly aware of the growing use of simulation and the demand, but also the evidence to justify its use as part of a clinical placement program. So I am going to continue to pursue the relationship with them and continue advocating that they need to recognize that in their accreditation programs. And of course, they accredit based on what the accrediting bodies and regulatory colleges expect. So have the links then to the accrediting to those colleges. And there's certainly an important challenge for advocacy as a national voice in the near future. Getting back to if anyone using virtual patients, so just a few quick notes here. Gabriella Rispoli is using Laerdal's The Point. Sarah Ritchie says they're using Elsevier's virtual simulations at the University of Toronto. They're going to be starting on Monday. That's from Manjeet, although it doesn't say what platform they're going to be using. Aurora Vandenwerk says we are using a combination of vSim, which is from Laerdal or Wolters Kluwer, and Shadow Health for their practicum students. see things. Jamie Coleman mentions simucase.com for speech language therapy OT, and they're beginning to have patient cases. Thanks for drawing my attention to that. We'll add that to our list, Jamie. Do I know how much time is allowed in Alberta? Unfortunately, I don't offhand. Maybe Cynthia or Barbara, if you happen to know that answer offhand, you can type it in and I'll share it. Response from University of Toronto. They're using Shadow Health's leadership course starting on Monday, and their maternity and peds pilots courses starting soon as well. And Menji kindly offered their email address if anyone wants to follow up with them at University of Toronto. I'm just going to paste that over into the chat window so you can see. Barbara's looking for the Karna's the Regulatory College for Nurses. She's looking for the document, but she knows they recently changed their position. Hopefully changed it in a good direction. Before we all sign off, I wanted to draw your attention to a couple other resources. One is that every Tuesday afternoon at 2 o'clock Eastern, we have a drop-in video conference opportunity for anyone, whether you're a member or not, anyone who wants to join, it's open. This is just an open forum for simulation educators who are facing challenges with distance learning and virtual simulations, to share ideas, share successes, so we can learn from each other, because there's some real gems of innovation and some real gems of resources out there that this is a perfect example of a time when we can share our learning. Nicole mentions, I see that someone is asking about resources in French. So in French, there's a company called, I think it's called Interaction Healthcare. That's from France, that have some virtual patient platforms. I'm gonna have to look into that for you. Body Interact might be available in multiple languages. I know it was built in Portugal, and because it's European, they might be more sensitive to making it available in several languages. UBSim is a company out of Montreal that builds virtual reality nursing simulations. Not quite the same as virtual patients, but I know they've also built a mechanism whereby faculty can record themselves doing a virtual reality simulation and then share that with learners in order to facilitate a discussion around what was done well or not done well in that virtual reality simulation. Aside from those, none others come to me, but thank you for drawing that to my attention. And I think going forward, as I update this list of options, I will include a comment about available languages to help make that easier for Francophones to find platforms that have French resources without having to dig through everything. Would I say that most of these virtual simulations are accompanied by debriefing sessions? Can I comment on this process? So I would say absolutely, they all have to be accompanied with some kind of feedback. Not necessarily debriefing in the sense we know that, but they absolutely have to be inclusive of feedback. And feedback can come in a few different mechanisms. One source of feedback, if you have a branching or an evolving or responsive virtual patient, is the learner is going to get feedback right away and see how their patient's situation changes based on the decisions they make. But it's not going to tell them necessarily why. So it's important to also include, and most of the virtual patient platforms, in fact, I think all of them on this list, include feedback so that at the end of the case, learners can review feedback, and the case will track the decisions they made and the actions they performed along the way and be able to provide feedback on them. So this is all programmed into the case ahead of time. So feedback can be provided about why a certain decision or action was ideal or not. In some cases, like if you're doing an interprofessional virtual patient, you need to include debriefing in the more traditional sense. And the facilitator needs to take a more active role, both in real time and during a structured debrief session. Some people have used cases very effectively, myself included. Rather than having students do a virtual patient individually, you could bring students together on a web conference, a small group, and screen share from one computer and walk through a virtual patient together. And that way, as a content expert, you can, if needed, debrief in real time. You can have your learners collaboratively decide what actions to take next and discuss pros and cons of different actions, see what the consequences are, and then, then as a facilitator, you then have the ability to intervene if you see people getting confused or off track, or allow them to make their decisions and wait till the end, and then do a post-case debrief, like would be more common in a mannequin-based simulation. The paper by Mark Verkyle does a nice job of summarizing some of the pros and cons, and I think it's not a question of which is better to provide that feedback or debriefing, but rather what's more appropriate in what situations, and what are the pros and cons of each, and what do educators need to be aware of to make sure that feedback is good. That's it for the questions that have been posted. We've gone 10 minutes over time, so I'm going to suggest we draw this to a close. If anyone has suggestions for how Simulation Canada can help, please send them my way. We know it's a challenging time, and I'm happy to do anything we can to try to help. We know that the use of virtual simulations is rapidly being adopted, and even if the pandemic settles and things are more or less back to normal in September, I would be very surprised if we go back to business as usual. I think the use of virtual patients to complement high fidelity and standardized patient-based simulations is likely going to endure, because we're going to see the benefits of it. I'd like Simulation Canada to play a role in helping everyone make that transition, identify best practices where they exist, share resources when possible, because there's a lot of upfront development work that goes into these programs, and the more we can share learning, the more we can share resources, the more we'll all benefit. Right, so thank you everyone for joining during a hectic time. Like I said, any questions, follow up with me. Any suggestions, please follow up with me. And please stay safe. And thank you all for the work you're doing to continue your education programs as best as possible for your learners. And for those working in the clinical space who are working rapidly to help healthcare providers upskill or reskill or refresh in order to keep them safe. Thank you. Have a good afternoon, everyone. Look forward to hearing from some of you. Bye for now.